Thank you for your time this morning. My name is Russ Alford. I'm the General Manager of the Medical and Research Solutions Group, which is a wholly owned subsidiary of the Turner Construction Company. We operate independently. We're more leaning on the design side, where Larry and his group is obviously on the construction side. But as a follow-up to Webb, I will tell you that we built a lean company. We were in a great position to hire talented people to help us form the company. But UHS was the first real lean client I ran into, and Bill Seed was leading that job. So we had proposed on a project in Temecula. We were shortlisted, went to come to the interview. I asked Bill what we should prepare, and he said, if you can't put your whole approach on an A3, don't show up, right? So we presented our first A3 to a client at Temecula out in California and helped a little bit with that project. So let me take 1 minute and explain why would Turner have a medical equipment company that is really working on the design side. It's really through our experience. The company does about $2.5 billion of healthcare a year. That's 180 to 250 projects annually. So we started seeing the same problems reoccurred, and we decided to really take a look at the problem, try to see if we could go in there, and it started to be managing the gap. As those of you in the design industry know, there's a book that we all depend on at the beginning of the job, but sometimes clients change their mind clinically at the end of a job. And so as a construction company, Larry wants every piece of information available at the start. As a clinical entity, they really want to wait and delay those decisions until the last responsible moment. So that's really where we started. How do you define that last responsible moment? And how do you help those clinicians see the solution before it's there? So as equipment planners, that's really our vision. We need to see through the eyes of a clinician to be effective with what we do, right? So that said, we were seeing the same reoccurring issues. BIM was developing 15 years ago. Revit models were developing. We were starting to show fly-throughs. We were just trying different ways to help clinicians understand what that final vision was. But we kept hearing the same thing. I think that might work. That looks like we used to do it, and that probably will be okay. What happened when we built that facility? It didn't work as much. I see the owner in here shaking, right? So it's different, right? And as design and construction professionals, we are in the business of visualizing solutions before they're built. Clinicians have a very different vision, right? They needed to see the solution differently. So why change? We had to, right? We were seeing reoccurring problems, and my epiphany really came on a job out in Kansas City that we competed for the planning and lost. We had pitched a virtual solution. The client went another direction. I got a call about 3 months later. It was a couple biplane rooms and a renovation inside the hospital, and they said, we have a problem. Design has been stopped for 9 weeks. We can't get their neurodocs to sign off. They do not believe the room will function in the size that we're building it. Can you bring that virtual thing out and show them how it works, right? So we set up the system. We took 9 neurodocs through the room in 30 minutes, got a sign off, got the job back started. At that point, we made a major investment into a custom system that you'll see if you have time to look behind. But this is what our clients look like now, right? We never saw this in a conference room. We never saw this in a cardboard mock-up room, right? We now are putting clinicians into a real environment, right, where they can interact with the room, and instead of hearing, I think that works, we're now hearing, I see the space, now I can see me in the space and how I use it, right? So what I want to show you today are a couple of videos that show our lab, how it works, and how we engage clinicians. But we realized VR was probably the solution we needed to go because it started to solve the problem of the clinician vision into the space. We needed to find a way to create a true-to-life experience. Not the cardboard box hanging on fishing line and telling them that was their Skytron monitor. It was a different world. Presence is the key characteristics. What we're doing through the advance of BIM and Revit models, we're able to turn clients into avatars, simply put them in that model and let them interact with the space in real time, real scale, and very realistic. Virtual reality for anybody who has ever been in a set of Oculus goggles, a virtual set of goggles, all right? So or half of us have seen a little bit, very different view, right? And so that's kind of the start. When you put your goggles on and you can look around the model, you have that first level of interaction. What I'm going to show you today is full immersion. So a step in a virtual model is a step in real life. And as soon as you take that first step in that model, you go through a physiological change and your mind transports into that model. It works, and we see it all the time. And we'll be interested to play with some of you in the back room there. But it helps clinicians feel the room. They can start understanding workflow. There's plenty of room behind me. Why is that cabinet there? And so we heard the words change immediately from I think that might work, that looks okay, to I need that monitor to go up a foot and over to the right. Why is that cabinet there? It should be there, and the sink should be on the other side of the door, right? A completely different level of confidence, which raised decision-making to a higher level and expedited it tremendously. And it gives everybody a voice. We found when we were in we had a surgical team at a conference table, there were two people that lead that team who gave all the input. Everybody else kind of falls back a little bit. Well, what happens when you put people in a virtual room, they go, why is that there? That should be over here. We didn't hear that in that paper meeting. We didn't hear it when we had the scale CT going in and out over the table, right? So it changes it. What I want to show you here is kind of how it works. What you see in the lower right corner of this is our lab. We have a lab in Nashville, Tennessee that doesn't have any of these lights in here, so we don't have to do this. But to the gentleman back there, we do have virtual meetings. We are able to pull you and 14 other people from wherever you're at in the country into our lab virtually, and we look at each other's avatars. So when we have a question about the room, we simply ask you to put your headset on, set up a virtual go-to meeting, and get in the room. We'll have that discussion from inside. Yes?
So you can have multiple people in the same virtual room at the same time?
We can have multiple people in multiple states concurrently in the same room. Clinicians do not have to leave the workforce. You do not have to leave your desk, right? So when you put the headset on, we've got an equipment planner in the room going, Dr. Smith, what was your question about OR4? And you're in OR4. So the discussions, again, ramp up very, very quickly. Let me show you a little bit about how it works. And so what you're seeing projected is what Zach sees through the goggles. And you'll see very quickly when he takes a step forward in real life, it is a step forward in that room. Everything in the room is movable. We can plan the room in real time with the clinicians. Zach's going to show you his Herculean strength and pick up the bed and throw it around. But even the wall-mounted items, right? We do this a lot in patient rooms where the entire discussion is patient side, family side. And where should things be located and how does it work? Very hard to get that realism in cardboard, very easy to get that realism here. I want to show you another look, which really is what the user sees, right? So the user, and this is an actual OR in Ohio. We had two systems that combined. They had a very old OR. We were trying to show them a completely different layout. But as you see, everything in the room is very realistic. If you have Skytron booms that have 135-degree knuckles and stops, that's exactly how they operate in there. So you can get your spacing, you can get your understanding. We see anesthesiologists all the time ask for a chair. They want to roll the chair out. They want to sit at the head of the patient. They want to pull the equipment boom around. They want to see if people can walk behind them, because anesthesiologists do this a lot in surgery, right? They get bumped, right? So their big concern is there enough room for me to do my job and make it work? And I'm sorry I'm talking really fast because we're a little bit late, but Mimi's looking at me like, hurry up. So what I want to show you here is that same OR that you saw the users viewing it. This is a real design session. It actually is being run in a mock-up. The owner did want a physical mock-up of the room for training, but they asked us to go in there and get the room as fully developed as we could before the mock-up. Recognize here, we're at less than 50% SDs on a job, and we're having a level of conversation to this level that you really go in 30 minutes from an SD level conversation to a CD operational conversation in a matter of minutes, not weeks. This was a session where owner gave us 2 days to get 19 surgeons to sign off on a general OR room at 50% DD, right? And so we brought in the charge nurse for a day, explained to her how it worked, let her play in the room for a whole day. That's the voice they were used to hearing in surgery. So we wanted to make sure that the questions were answered by the voice that they were used to because they can't see her. This is a pretty old hospital. This is carts and hose reels. So she's coming to an OR for the first time with all ceiling mounted equipment. There's virtually very little things on the floor. And she's standing at the table and she's really trying to set up. She's pulling monitors around, she's pulling cameras around, she's pulling lights over, and she's asking a lot of questions. I mean, how should I be doing this thing? At the end of the day, all 19 surgeons signed off in 2 days. Design went through. There were no changes from 50% SD through that final construction document in that room. But as you can see, she's in that room. And she's experiencing that room. The system works very much like a Wii. You have a hand controller that you can grab things, you can measure things, and this is, I don't know, maybe 5 years ago when our computer was about this big to do this. Now our processor is about this big, so it's a lot easier to travel with, and so instead of a team of mules, Zach can carry it himself. But very realistic, and the room that you looked at from the user view is the room that she's in. Anybody ever been in this kind of virtual environment? It's a little different from most people's paradigm. I have one more example I'd like to show you. This is a 250 bed LDR on the East Coast up in Virginia. And these are the kind of spaces we see virtually mocked up, either highly repetitive spaces and or highly technical spaces. This was a 250 bed room. We had the entire nursing staff in the room. So it's a setup very much like this. We had different users in the model. We were projecting on the wall to be a little bit more collaborative on what was going in. But you see, and she wasn't very good with the Wii, so that's one of our planners. It's actually going back through the discussion, replacing items on the wall. We saw the nurse call move 5 times in about 3 minutes, right? Now, on a real mock-up, we'd have to cut that thing out. You come back next week, we show it over here, or maybe it's a sticky note. But in this situation, it's real. Right? And so there was a huge discussion of family side services versus clinical side services, and things kept going back and forth. Everybody had a reason to put it there. A lot of people had a reason why it shouldn't be there. But at the end of the day, head walls were reconfigured, the room was reconfigured, and we were able to give the architect a final recording of the discussion, of the movements, and how the final room was outfitted. Any questions on this and how it works?
What do you find as feedback from the users after everything's in place and functional? Do they say, yeah, that's pretty much like I saw it in virtual, or it's still a little bit different and I would have liked to do something else?
They say it's exactly like I saw it. So client satisfaction has peaked with this in that they're getting exactly what they believe they were getting. There is no switch in visualization from a mock-up, whether it be cardboard or real. Now, obviously, a real mock-up in the OR room is $800,000, $900,000 worth of equipment. Very difficult to get in and get out. So our system, we have thousands of pieces of equipment. So if a doctor is hesitating in an OR and says, what if we go to robotics and I need a Da Vinci in here? How do I know the room's big enough? Bang, a Da Vinci comes in the room, they're able to manipulate around the table, make sure, so we can go through hundreds of scenarios a day in every single room. So when we get those what if questions, it's very dynamic conversations.
Have you really done some of those where you have people in different states? How do you do the goggles? Just ship them the goggles for the session? And
It's actually a small set. We've done it with, we have a partner in Santa Barbara, California that we've partnered up that builds our systems for us. They have a partner in Germany, so we have tested this from Nashville to Santa Barbara to Germany, and it's talking just as if we are here. Now, I am tall, dark, and handsome as an avatar, and not that in real life, but that's a whole different thing. So,
How do you get them the equipment they need to be a part of this?
we have a small box that we can ship to a client. They open that box, they press the button, they put the headset on, and we're ready to go. Right? So we have seen more systems. Our system is a very expensive system that tracks very accurately, but we're pretty tickled that we're seeing some architect partners are now buying the Vive systems, and for not a real big investment, you can buy a small tracking system. So on larger jobs, we propose to leave one of those systems on site. So when design partners or clinicians have questions, you simply walk in the room, you put on the headset, and the partners that you need to talk to are in the room. And for us, the room really exists in our lab, right? We just move that around, or we move you to the lab, and we don't have fully tracking bodies, right? It's very expensive. Those who have seen those sports shows where they have a sensor on everybody. We really have sensors on your hand and your face. We want to see where you're looking. We want to see where you point at, but you're kind of a creepy head and a couple of hands right now. And so we're working on how to make that flow just a little bit better. But we find that people don't really focus on the avatars. They focus on the room. That's what they're there for. That's the vision that they want to see.
How do you translate the changes back to the design team? If this is done in STs, and I think it's really great, but as people are moving back and forth, how does that get translated back to us for permit and construction documentation submittal?
That's a great question, right? There is no interface that goes back to Revit, right? All of our models are based on the architect's Revit model. We simply pull an excerpt out of your model, that room, and whatever's in that room when you give us that model stays in that room. We put all the things that you'd like to move. But we can record the sessions, but we can't unvirtualize it and turn it back into Revit. But we found that the architects that are in the room that experience a session hear that high level of discussion, and we do record the sessions, as you've seen, so they can play those back to get it right.
And they can hire you, Turner, for this portion of discovery in
Yes.
schematic design.
Yes.
It would be a lot less expensive than doing a mock-up.
You know, it's interesting you say that. When I've been with the company 35 years, I have been running the MRS group about 10 years. But when I came to MRS and started realizing the capability that people like Karen were going to make me do, and some of the budgets from my past jobs is spending $500,000 on mock-ups. For $500,000, we could mock up the entire hospital virtually and have you go through every room without ever having to build something physical.
So we don't do that. We only do the push and shoes, much lower cost, and much faster.
Come on, Karen. Oh. And let me just hit a couple of points here, and but it's different. When you saw the pictures of our clients and you see him trying to reach out to touch the table, that happens every session. There's nothing a surgeon can do from walking up to the table and going, all right? It's that real, right? But they're feeling that space. And when they walk into that room and they feel their presence in that room, their confidence goes up. Their reduced learning time of this is exactly what my room looks like. They're very quick to interact, right? So we're seeing a much heightened decision time. And so we go from 10 meetings to 1 to get the same information. We're reducing the clinical time that they spend in meetings. It's when you look at a surgeon as $15,000 an hour and what you're spending for those rooms, you just can't take that deep dive to take everybody to the warehouse and walk them through the cardboard and convince them that it's really going to look like this when you get there, because it's not real. Confidence, understanding, excitement goes up. The example I gave at the hospital in Kansas City, we went to the cafeteria at lunchtime, and I'm sitting right next to the table of a couple of folks that were in the room, and they were telling their peers, "You're not going to believe it, we were just in the new biplane room." And when I thought that's not built yet, Well, not really, but we were in it. You're not going to believe it. It's big. There's plenty of space. The control room's bigger. You have a great view. They are describing the room because they remember those things from that presence in the room. And so there's no real information lost. When people go experience the room, you show up the next meeting, they're right where you left them off. Functional, change on the fly. Healthcare has changed dramatically in the last 10 years, and so we're seeing more and more clients go, what if I wanted to do this in the room in addition, and this and this? Can we fit all that? Is that option here? How much bigger do we need to make the room to get maybe 2 more service lines into that room? So gives you a lot of opportunities, and it is collaborative. Everybody's there, everybody participates, everybody has a voice in that room. It's just a better vision. So I started this with saying, for us to be effective, we really need to see through the eyes of a clinician, this is how we figured out how to do it.
Yeah, well, so just to share, probably piggyback on your question over there, the first time we used it in Florida, to my knowledge, we were doing an emergency department expansion at Miami Children's Hospital. And the struggle we were having, they had a budget of $150,000 to build just 2 modular rooms, a treatment room and a fast track room for the ED. Well, they didn't have space to really build it, so we're scrambling. We're going to rent a warehouse somewhere and additional costs. So we pitched and proposed this virtual reality, and they loved it. We just needed just one little room. We spent, I think it was $42,000 back then to get the system set up in the room. We worked closely with Perkins Boyd, the architect on that project. And in 3 days, we had, I think, 80 staff come through. Everywhere from maintenance folks, security, obviously the users, nursing and whatnot. And generated 3 pages of comments at that time. It was 4.5 years ago, so it's come a long way since then.
Yes.
But the aspect was they didn't have a place to build a mock-up, and $150,000 was just going to be thrown away. We built it, tear it down, and we did it for, like I said, a little price.
Let me infuse the question in that the question couldn't get sign off in the NICU until she could see it. And she was in a position, it was I believe an octangular NICU bay. There were 8 to 10 patients. All the rooms were set up same-handed. We've heard that before, right? Right? That was a design principle. Everything had to be same-handed until she got in the virtual model and sat down and said, I can't see those 4 patients' heads. So, left-handed rooms, right-handed rooms, right? As simple a concept as that was, you couldn't look at a piece of paper and understand the sight lines that you had from the nursing station into all 8 or 10 rooms. And I apologize, can't remember how many that is, but virtual was the perfect application for her, and she actually had a chair. She could see it stand up, and she said, I don't stand up at my desk, I need to sit down. Right? And so I believe the counter got lowered a little bit. All the right-hand rooms got flipped into left-hand rooms on the right side, and all that was really changing the clinical family side of the bed. Right? So we didn't have same-handed rooms anymore, but we had a much better clinical solution. Thanks for that, Larry. With that, I think there's nobody after me, Mimi. We have the system set up there. It's been very tough to set it up in a very small area. The system uses infrared cameras and will go to a 50-foot by 50-foot grid. So we could have a very large area inside the trackable area. We're set up about 10 feet by 10 feet back there to really just show you how it works and let you play with some things if you'd like. But system, we hope, operates pretty good with all these lights, but our issue is infrared cameras and incandescent natural sunlight don't work very well together. So, but with that, I thank you for your time, and if you're interested in any of this and how it works, or you want to be an avatar, if you're a design partner and you're getting into virtual, we want to help you get farther, right? We need more and more people into this platform so we can do more and more things. We were very, very isolated 4 or 5 years ago. We're starting to see some firms start to sign up and really look at this technology.
I just have obviously the equipment's incredibly expensive. Are you so busy that you couldn't be commissioned to do something for someone, to build a model for someone in a timely way? I mean, it makes so much sense. If it costs less than doing, a mock-up,
Full mock-up, yeah.
it doesn't take up any room. You can do it any way you want. So I would think that every major healthcare facility would go through some sort of a process like that. So how busy are you when you sign up to get a model built? How long does it take to get one built?
It's a great question, and we're not too busy, but certainly our virtual reality group has exceeded our business model, and that you're right. There are jobs that we are not the planner on, but we are still doing the virtual mock-ups for the client as a result of sessions like this. Depends on the room. The grayscale OR that you saw is about a week, right? So we have a library of thousands of pieces of equipment, but it really depends on what you as a client, what that model to look at. We're going to show you a very high-end model today that you're going to see the lights reflecting off the floor. You're going to see when you walk into the OR timer starts. So a very sophisticated model. But it takes us about a week to put together a grayscale, and we found we don't need a lot of colors. And matter of fact, we'd prefer there not be. We don't want somebody walking in and going, "Why is the floor blue?" Right? We want shades of gray. We want you to understand how the how the we want them to understand how the room operates, not what it looks like. And so it takes about a week to put a model together, and it takes an hour to set up the equipment.
So all total, about how much would it cost to have the components you needed to do that production and the driver, someone who knows how to do it? How much would an architectural firm have to invest in terms of buying something like that?
It depends on your system. Now, there are some small systems. What's the one with the two towers, Zach? The Vive system, $10,000? $10,000, $12,000 to get into it. They'll do an operational space, maybe a 10-foot diameter circle. You can still put things in, take things out. Won't track quite as accurate as ours, but if you had a Vive system, we could simply transport to our lab, and then it's tracking in our system.
And is that becoming a requirement in all the proposals now for large facilities, that they have that that the architectural firms that are competing for that work, or the design build teams that are competing for that work, are they having to have that? Is that becoming
I have not seen that requirement on a single RFP. We offer it in every proposal we put in for equipment planning, just so the team knows if you get stuck on a room, we can get you unstuck pretty quick. But that's what tends to happen in design scenario. There's 482 rooms in a hospital. We get stuck on 2 or 3 rooms that are very difficult to get consensus on. We simply shift platforms, get that consensus quickly, and move forward. So we'd like to see it on every RFP, quite frankly. Just in case anybody's listening. So, but no, we think it's the way of the future. We think all architects will be designing in virtual in the next 10 years. I feel a lot better now that there are other companies out there. We were clearly on the bleeding edge 8-9 years ago when we jumped into this. It was a lot of money for an unknown test and an unknown solution that, quite frankly, it was too Jetson-esque. People didn't believe it until you put the headset on. But a lot has changed. The headset that you saw the surgeon in Ohio wearing was a $55,000 headset. You now can buy a great headset for under $1,500. And so it, just like all things in the world, it took a little bit of scale to get the cost. And so the fact that you can go buy a headset for less than $1,500 and buy a fully trackable system for $10,000 is pretty interesting. So we've got 2 or 3 different architectural partners who have taken the leap. We have several industry partners that are vendors, the GEs, the Siemens, that are all adopting this platform so they can help. They're in the same business we are. They're trying to teach that clinician how to use that equipment to be more effective. And they found that virtual platform to work. We've had clients have asked us to do OR sessions so they could recruit docs. They wanted to show them this is how we communicate to our surgeons in design. We have clients, we have a client out in Oklahoma that has said, hey, we're doing groundbreaking. Can you set the thing up so we can show people what they're really going to get at the end day? So we're seeing different uses for it than what we designed it for, but it works very well for what we like to use it for.
So, I respect everybody's time. It's optional to stick around for another hour. Russ and his team has some demonstrations set up that you can put the goggles on and step into some of these rooms. As Director of Healthcare, again, I want to thank you for taking the time to be here today. I do want to thank Mimi Flatley for helping set this all up. Mimi,